let's go ahead and start grand round. So, Randal White, one of our chief residents and graduating residents, thank you grand round today. He takes an important topic, so we need up to 5 questions about ethics. So, Randal.
Okay. Thank you, Dr. Bocchini, and thank you everybody who came out today to listen to my grand rounds. So I have no disclosures. So this is an important topic. I think it's one that kind of permeates everything we do as physicians and practitioners, whether we realize it or not. It involves every decision that we make on a daily basis. And it's one that I don't think we talk about a whole lot. So I wanted to kind of give an introduction to it, an introduction to some fundamental concepts, and kind of use it as a springboard for you to go and look up some other things that you may find interesting when I'm done with this talk. And hopefully there's some things that you think about afterwards. And I kind of thought of it as sort of like a trailer. So if you go see a movie trailer in the theaters, you kind of get a little introduction. You don't get the full story. You don't get a comprehensive overview. You don't see the whole 2-hour movie, but you kind of get excited about it, and maybe it's something that you come back and see at the theater after you see the trailer. So when I was organizing my talk and doing my research, I felt a little overwhelmed at the beginning. I didn't know how I was going to form a less than 1-hour talk on such a broad topic. So the way I broke it down was, I thought if you could have 5 questions at the beginning of the talk that maybe I didn't know the answer to, that and at the end you could answer these questions, then maybe you could have a good introduction to the topic of medical ethics and pediatrics. So that's how I structured my talk. So what are those 5 questions that I kind of used to outline my talk? I just kind of went with easy questions that we could all remember: who, what, where, and when, and why. So, and I kind of reordered them in a way that I thought flowed well. So why? So why are medical ethics, particularly in pediatrics, important? When? This is kind of like a timeline of pediatric medical ethics. So how did they develop? Who are some of the key players that went into developing the different concepts in medical ethics? What are some of the major concepts in medical ethics? And this is kind of where I spend most of my time in my talk talking. And those are some kind of high-yield topics as well. Some of those things pop up on USMLE type questions and board style questions. Who makes the decisions? This kind of relates to autonomy and consent in pediatrics. This is a really big topic. So I do spend a whole section talking about that. And then the last question is where. So where can I find more information about medical ethics? So if at the end of this talk you can kind of give a 1 or 2 sentence answer to these 5 questions, then I think that we've accomplished our goal today. So why? Ethical dilemmas in pediatrics. And then when? A brief history of medical ethics. What's going to be a major concepts review? Who? Autonomy and consent in pediatrics. And then where you can get some resources for ethical considerations. So my first question is, why are medical ethics important, particularly as related to pediatrics? So first I want to talk about this study I found that was a 2016 study in the Journal of Medical Ethics. It was a study performed out of Boston. It was a cross-sectional survey, and they looked at young, recently graduated pediatricians who had finished residency recently. And they basically gave them an ethics quiz, a validated questionnaire that dealt with important medical ethics topics. And they had 370 participants who took this quiz, and the mean score that was given was 17 out of 23, which equals a C, so not too bad. The most missed items on the quiz included topics that dealt with genetic testing of a child, topics that dealt with patient confidentiality, a question that dealt with life-sustaining technology, and a question that dealt with assent and parental permission. So those are really big topics in ethics, and I think we're going to touch on those a little bit today. And kind of interesting in the study, they also, one of their variables was whether or not the individuals had received like formal ethics training, whether that be in medical school or in residency, and it showed that the scores were not correlated at all with formal ethics training, so I thought that was kind of interesting as well. So, pediatricians, at least in this study, had a kind of a good understanding, got a C on medical ethics, but it looks like there's some topics too that we could probably improve our knowledge on, some concepts that we could learn more about. So I divided up the ethical dilemmas that a pediatrician could face into two kind of broad topics. Everyday dilemmas. These are dilemmas that you could face in the office on a daily basis. And then I also looked at what I call societal dilemmas, or these kind of have more global ramifications, global decisions, global impact. So what are some dilemmas that you can face every day? And this really goes for not just pediatricians, but any practitioner. So maybe you have a patient who's in a poor social situation, so you may think that a certain medication or certain treatment would be ideal for this patient. However, because of their financial situation, their insurance situation, they may not be able to afford it. They may not be able to pay for it. So you have to give them the runner-up treatment. You have to decide, you have to balance out that situation where they can't afford maybe what you think is the best, and so you go with something else. This is a big one in pediatrics, confidentiality. And the example I gave here is maybe you have a mom that calls or a dad that calls wanting to know about their 17-year-old son or daughter's STI testing. And you have to deal with that issue of confidentiality where they're not a legal adult yet, but they do have some autonomy and legal authority there to make decisions about their own body and who decides or who gets to know their results or their choices. There's some issues regarding professional authority, and I think that anyone who spent some time in the general clinic knows that we'll have families come in and they'll ask for maybe a letter to the electric company that says, my child has this medical equipment home. If the electricity's turned off, the child won't do well. Maybe they have some mold in their apartment and they ask for a letter to give to their landlord that says that this is an unacceptable situation. My child has allergies. They can't be around mold. So we have to balance our professional authority there, and that's an ethical dilemma as well. And then this, I think, is probably one of the biggest ethical situations we face is that we have to balance the relationship when we have a family who maybe disagrees with us. I think probably the most common example that we talk about a lot, that we come across a lot, is a family who doesn't want to vaccinate their children. And we have to, and I'll talk a little bit more about that later, but we have to have a good alliance with that family to do what's best for the child. So those are kind of what I looked at as everyday dilemmas that we face in pediatrics. Now, what are some more societal dilemmas? What are some, you may see these on the news, you may see these on the internet, and then these may be things that we don't have to make a decision on a daily basis, but they do have certainly important ramifications in pediatrics. I'm not going to spend a long time talking about most of these, but I just kind of want to throw them out there. So topics related to organ donation, genetic testing of children, human embryo research, issues dealing with autonomy, palliative care, informed consent, and then I change the color of those because I do want to spend a couple of moments talking about these two topics. So withdrawal of care and pediatric euthanasia. So I'm sure if y'all remember back in April of this year, there was a big issue dealing with this little 23-month-old boy in Britain who had a rare neurodegenerative disease. From what I could find, they weren't ever able really to give it a full diagnosis. But this child had been in a semi-vegetative state on multiple support devices for many months. And the physicians who were taking care of this patient in Britain decided that it was time to withdraw care, that it was futile, there was nothing else that could be done for the child. This is a situation in which the parents didn't agree with that decision, and it became a big legal battle. Went to the high courts in Britain and actually went to the European Union courts as well, and they all upheld the decision of the physicians in that particular case. And what was interesting here was that the parents wanted to move the child to a different facility in another country, some other hospitals who had volunteered to help take care of the child, and they weren't allowed to do that based on the legal decision. And the care was withdrawn and the child ended up dying. So that's a kind of a very complicated ethical issue where the parents wanted to move the child and they weren't allowed to. Something else that I think that we're going to have to address, and it hasn't really come to the United States yet, but you can see it in some places in Europe, is the concept of pediatric euthanasia. So in 2002 in Belgium, the Euthanasia Act was passed, and that said that adults who decided that were of sound mind and decided that they had psychological or physical suffering that was unbearable, they could decide to have themselves euthanized. And it wasn't applicable to any kind of minors or pediatric patients. In 2014, however, they passed an amendment that said that it could be applicable to pediatric patients. They had a few qualifiers on that. It could only be related to physical pain, and the presumed death of the patient had to be within a short time period. But it did expand that, and it had to be signed off on multiple physicians. So it did expand that to pediatric patients. And then in 2016, they didn't say the age of the child or what they were suffering from, but a child was euthanized in Belgium for the first time. So we may think that that's not something that we're really, an ethical dilemma we're having to make a decision on in the United States, but just earlier this year in Pediatrics, there was an opinion piece entitled, "Should Pediatric Euthanasia Be Legalized?" So I think it's something that we're going to have to talk about and approach as pediatricians at some point during our careers. So I hope that kind of makes it clear that, talking about medical ethics and having a good foundation of medical ethics is important. So I kind of want to switch gears here a little bit and talk about our next question, which is just talking about a very, very brief overview and timeline of medical ethics. I think it's important to understand how some of the concepts that we deal with today, how they evolved over time. So any good ethical timeline discussion starts with the ancient Greeks. So Aristotle had a system of ethics that dealt with virtues. So it was virtue ethics. There were certain virtues that he thought an ethical person would have, and some of the most fundamental ones for him were prudence, temperance, courage, and justice. So he said moral virtues are states of character, a disposition to excellence that makes one a good man and causes him to perform his function well. So an ethical person would have these virtues, and using these virtues, and through these virtues, they would make ethical decisions. Jump forward a few centuries, we get to Hippocrates, who I think we all know pretty well. And he thought that the physician, their ethical goal was to promote the well-being of the sick and relieve suffering. Some other important players were in the time of the Ostrogothics in the 5th century. I had to read up a little bit on them because I wasn't 100% sure who those people were. But there was one of the first codes of medical ethics published, the Formula, and if I say these things wrong, I'm sorry if I pronounce them incorrectly, Formula Comitis Archaeatrorum. In the 9th century, Ishaq ibn Ali Ruhai published one of the first Islamic code of medical ethics, which was translated to Conduct of a Physician. And then we have Maimonides, and he was a Jewish physician and philosopher in the 12th century, and he also had various concepts of medical ethics that he had as well. And there's actually a code of Maimonides that similar to an oath similar to the Hippocratic oath that people can take as well, physicians can take as well. Then we kind of get to the Enlightenment, and we still are kind of calling this concept of virtue ethics, and we kind of had a shift of ideas during the Enlightenment period. And then we had other concepts that permeated ethics that kind of replaced that more ancient concept of virtue ethics. And so that would be John Locke, which if you studied American history, you know him, and his concept of rights, and then Kant and deontology, which basically says you look at the act itself to see if it's ethical, not necessarily the consequences. Kind of the reverse of that is Bentham and his concept of utility, which is where an ethical decision, when making an ethical decision, you consider all of the possible outcomes and the likely outcomes and try to maximize the good or the utility for the different parties that are involved. Two big players that I wanted to talk about too in the 18th century are John Gregory and Thomas Percival, and I think they contributed a lot to kind of the modern medical ethics. John Gregory, this is a Scottish physician in Ephesus, and he kind of reformed thinking of being a physician into a profession rather than just a job or a practitioner. He saw being a physician as fiduciary to the patient. So it wasn't your traditional entrepreneurial type transaction. The physician had a responsibility to the patient as well. It kind of changed the thinking of buyer beware type approach to physicians, where the patient was responsible for their decisions and responsible for what they were getting, and put some of that responsibility on the patient or the physician to be a fiduciary to the patient. He said his primary concern was the health of patients, and then the secondary concern was your own self-interest. Thomas Percival was one of his contemporaries. He was an English physician and ethicist. He saw the profession as a public trust, and he was one of the first people who started talking about sick individuals as patients rather than the sick, or the Latin term was agrotis, and that was kind of the term that was used for sick people prior to that. And he actually published his own journal, or his own medical ethics called, very long title, in 1803, called Medical Ethics, or a Code of Institutes and Precepts Adapted to the Professional Conduct of Physicians and Surgeons. And that's actually where he coined the term medical ethics. Which brings us to today, and we have the American Medical Society Code of Medical Ethics, and then we also have a section in the American Academy of Pediatrics, the section of bioethics, which was founded in 1988, and they're dedicated to providing, pediatricians with various policy pieces on ethical topics, and they want to promote the importance of compassion, sensitivity, and high moral standards in pediatrics. So I hope that kind of gave you a broad overview of some of how medical ethics developed over time, starting in ancient Greece until today. And you can kind of see how you have this concept of virtue ethics, and then this entrepreneurial type relationship, and then this concept of being a physician as a profession, and the physician being fiduciary to the patients. So I want to talk now about some major concepts in medical ethics. This may be where you have some concepts and topics that pop up on USMLE type questions and also board style questions. And this is, I guess, probably the longest section of my talk. So these are some major concepts. So what is medical ethics? The World Medical Association Director of Ethics, Dr. Williams, said, "Ethics is the study of morality, careful and systematic reflection on and analysis of moral decisions and behavior, whether past, present, or future." And he said morality is the value dimension of human decision-making and behavior. I looked at the major concepts in medical ethics kind of under three different subcategories. The topics that deal with physician, as the physician relates to society, as the concepts that relate to the physician and how he or she interacts with colleagues, and then also the physician and patient. So what are the major concepts that deal with the physician and their relationship to society? Well, as we spoke about earlier, medicine evolved into a profession, and it interacts with government agencies, professional societies, private companies. So you can think of private companies as insurance companies, you can think of professional societies like the American Academy of Pediatrics, and you can think of government agencies, I'm sure we can think of many of those. And the physician has to maintain a certain ethical standard and professionalism when interacting with all those different groups. Physicians also looked at in concepts of resource allocation to make decisions or give opinions. There's not an unlimited supply of organs that are donated. Not everyone who needs an organ gets one, and society looks to physicians to help us figure out how we decide those are allocated. Public health topics, the physician also has an ethical responsibility to promote those, and we can think of different vaccination campaigns or different knowledge campaigns, different outreach programs that the physician can be involved with that helps promote public health. So those are kind of some ethical things that deal with the physician and his relationship with society. The physician also has to maintain an ethical standard when interacting with colleagues. The World Medical Association said that my colleagues will be my brothers and sisters, and we interact in kind of a traditional hierarchical structure of medicine that's been present for a long time. And we have to maintain certain ethical standards when interacting with one another, all the way from the top of the food chain to the bottom. And we have to keep in mind that there's this concept of the hidden curriculum in medical training. And that basically says that it's how we interact with one another, how students or residents or anybody sees other people interacting with other physicians or with patients. You learn how a physician should conduct themselves based on how you see people interact with one another. And that's the concept of the hidden curriculum, and it's just something to keep in mind. Physicians, when dealing with colleagues, we also self-regulate. So if we see a problem or if we see something that we think is unethical or not done appropriately, we have a responsibility to maybe talk about it or report it or talk about why it's not done correctly or why we think maybe that wasn't the best idea. Physicians shouldn't have any kind of discriminatory behaviors, beliefs, or practices, and that's part of professionalism and upholding a high ethical standard. Physicians work together. So if you have a complicated patient, you shouldn't be afraid to ask somebody else who knows more than you, or ask, get subspecialists involved or work as a team together to try to figure out what's best for the patient. And this can be seen through contacting a subspecialist or having like a meeting where you all sit down and talk about a complicated patient. And then conflict resolution. So if you have an issue with one of your colleagues, you sit down and maturely figure out what the problem is and go one-on-one with somebody, and you approach different conflicts maturely. So those are kind of how a physician should ethically approach their relationship with their colleagues. And now I want to talk about some various topics that deal with the physician and the interaction with patients. And these are very fundamental kind of concepts in modern medical ethics. So one concept is beneficence. This is very fundamental. It says that a physician, pediatrician should promote the well-being of others. Any action you take should be in the best interest of the patient, and it's important to remember that healing is the primary purpose of medicine. So any action you take should be to promote the well-being of your patients, and anything you do should be in the best interest of your patients. Maybe even more fundamental than beneficence is non-maleficence. So this is the primum non nocere, according to Hippocrates. This is first, do no harm. So it's more important not to harm the patient than necessarily to do the patient good. So you should do your best never to harm the patient. And you have to keep in mind the principle of double effect. So any kind of treatment procedure that you do can have both positive and negative effects on the patient. And so when making a decision, you have to weigh both those positive and negative effects and balance that concept of beneficence with non-maleficence. So it's more important not to do harm than to necessarily do something good. This is a big topic in all of medicine, and in pediatrics particularly as well. From what I looked at, this is kind of a younger concept, I guess, maybe than beneficence and non-maleficence. So, and this kind of evolved out of the turning away, I guess, of paternalism towards a more autonomous type approach to medicine and medicine decision-making. So, whenever you're going to do a treatment, whenever you're going to do a procedure, start a medication, you should really get informed consent. And what does informed consent mean? So the decision maker, and we'll talk about how this gets complicated in pediatrics, the decision maker should be presented with the possible positives and possible negatives of any kind of proposed treatment or medication. You always want to talk about any kind of alternatives you can have to whatever you're proposing. And you want to make sure that this implies that the person who's making the decision is competent and able to properly balance the positive and negatives when making a decision. Beneficence, which we talked about a few minutes ago, does not override the concept of informed consent, except where you have like a life-threatening emergency where you have implied consent. So if you have someone roll in the trauma bay and you start doing different procedures, intubations, different life-saving measures, you may not be able to get consent immediately if this is just somebody that was picked up on the side of the road in a car wreck, but it's implied that the patient's consent is implied in that situation because you're not able to get consent otherwise. So otherwise, though, you have to have informed consent. This ties in closely to autonomy, which is a very foundational value. Autonomy says that competent adults, and I want to highlight adults there, can make decisions about their care even if we see it as the wrong decision, even if we see that it's the decision that is not going to lead to the best outcome of the patient. This concept of autonomy is also kind of a younger concept than beneficence and non-maleficence. It kind of evolved from some of those Enlightenment period ideas, the idea of property rights, that I'm the owner of my body, that I get to make decisions about my body. And it kind of evolved from the older paternalistic view of medicine where the physician made the decisions. Prior to the concept of autonomy, physicians still use the concept of non-maleficence and beneficence, but now it has to be balanced with this concept of autonomy where the patient is the owner of their body. It does get a little more complicated in pediatrics, which is what I wanted to use as a segue into my next topic, which is who makes the decisions. This is kind of a discussion of autonomy and consent. So, in pediatrics, it's a little different than other fields of medicine. We have a unique relationship here between among three different parties: the patient, the parent, and the pediatrician. So when we make when a decision is made about a pediatric patient, there's three different parties involved. That's different from areas of adult medicine, where it's just the physician talking to an adult who consent or not consent for their particular treatment. But in pediatrics, we have this extra party that's involved. Things get complicated because people have different beliefs, different morals, different religions. Sometimes different parties may disagree about the outcome they want, but sometimes they agree on the outcome, they just don't agree on the way to get there. From what what I was reading said that whenever a physician approaches that type of difficult situation, there's three different choices that they can make. I think probably the first choice is what we do 99% of the time, where we try to find some common ground and ultimately respect the parent's decision, and you try to balance your viewpoint and your beliefs and what you think is best with the patient with what the parents think is best. In extreme cases, there's the other two choices. Sometimes there's a termination of the relationship, maybe from the parent side or from the physician side, when the divide is just too extreme to cross and that relationship ends up terminated. If we think that somebody's making a decision about their child that is hurting the child to a level that we find unacceptable, there's also different, at least here in the United States, protection agencies that can be contacted. So if we have a very sick patient and the family's just not bringing them to any visits, and we've all, I think, had to be involved with CPS before, then that's where protection agencies is contacted. So you can see how this parent-patient or patient-parent-physician dynamic can get really complicated very quickly and makes pediatrics kind of unique in autonomy. There's some important concepts that are implied when discussing autonomy. First is that whoever's making the decision has capacity, and what that means is they're able to properly weigh any positive or negative outcomes of the decision they're making. So they're able to really understand what the consequences are of their decision. And then it also implies that when a decision is made, that the physician respects that decision and accepts that that's what decision has been made. So let's talk about some different issues as they pertain to autonomy and that relationship between the parent, the patient, and the pediatrician. And we already kind of touched on this earlier. So we have kind of a complicated situation, I think, become pretty common, where a family and parents may refuse to vaccinate their children. This can be very frustrating on the physician's end, on the pediatrician's end, because there's a large body of evidence that shows the safety and the benefits far, far, far outweighing any risks of vaccination. And it also can be frustrating because the pediatrician may feel like that if the family can't trust me on such a fundamental topic, how are they going to trust me on other areas? We see this as such a basic, fundamental thing. And then when we have families that may not agree with us and don't want to vaccinate their kids, it can be really frustrating. And it may cause one to ask, how can I treat this child if they won't even trust me on something so fundamental as this? And sometimes maybe it can be tempting to say, I won't see any patients of or I won't see patients of parents who refuse to vaccinate. It makes the kids in my waiting room at higher risk for different diseases. It makes kids who are higher risk for diseases more at risk as well that are in my clinic. But it's just important to keep in mind that if you say you're not going to do that, those kids may not have anywhere else to go, and they may not get any medical care at all. So that's just an important thing to keep in mind when making that kind of decision. It's a good idea maybe to think about that kind of in the age of social media, that when you're maybe debating or discussing, I guess would be a better word, this decision with families, is that while you're coming from maybe where you're looking at evidence-based medicine, you're coming from a perspective of where you've had all these years of training, and these families, their only source of information may be what's available on the internet. They don't have access to all the literature we have. And it's just important to keep in mind as well that their decisions, they're not coming from the same place we are, I guess is what I'm trying to say. And one more thing on this, that those decisions, too, are often based more kind of on an emotional component a lot of times, I think, than maybe like a knowledge-based component. Genetics and genetic testing, this is another big field that deals with autonomy and consent. There's this concept of a right to an open future. And what that means is that a child should have the right to have as open a future as possible when they become an adult. So if they know about a diagnosis that you can't do anything about that presents, let's say, in adulthood, then you're kind of taking that autonomy away from the child as they get older to make that decision about if they want to know about that particular diagnosis. So if some kind of testing is done and they know that, in their 30s they'll have this disease and there's nothing that can be done about it now, then you've just taken away that right of the child when they become an adult to know about what they want to know about in regards to their body. It's important to keep in mind that the physician should always try to preserve this right to an open future, that any decision that should be made should be pertaining to their health now and then. I mean, of course, if something can be done now about something that may present later, that's a different story. But you should always try to preserve the open future of the child. You should always make sure that when they become an adult, they have as many opportunities as they have. Autonomy issues come up during that transition year from being a child to becoming an adult and adolescence. I already mentioned earlier disclosure of sexually transmitted infections, disclosure of different decisions that an adolescent makes in regards to birth control and choices about their body. Anytime you deal with a complicated issue like that, it's important for the physician to explore why the adolescent is making these types of decisions, explore the safety of the relationship involved that these adolescents are making these decisions in. It's important to encourage family dynamics. I think it's always a good idea to encourage patients to talk to their parents about what's going on. It's important to keep in mind that, let's say, an adolescent comes in and wants birth control, and they get it filled through their parents' insurance. The parents can, find out about it. So it's always a good idea to maybe talking to their parents, communicating, talking about what's going on, and then if an adolescent's choosing to engage in certain behaviors, explore why they're choosing to do that. Make sure they're not being coerced into it. Make sure that they're not, trading that for any kind of thing of value or money or safety or whatever they feel like they have to trade it for. So it's important to maintain or to give the adolescent autonomy, but also to explore why they're making the decisions that they're making. And then just always remember that our responsibility is to the adolescent patient. So I think sometimes maybe, we talk a lot about how to give, we need to give our adolescent patients a lot of autonomy, but they're still pediatric patients, and we need to make sure we explore why they're choosing to do what they choose to do. We talked a little bit earlier about informed consent. And for the most part, we talked about that relationship between the parent and the pediatrician and the patient and how it relates to the parent consenting to certain things. However, there are circumstances when the adolescent can consent as well. It's important to think about adolescents are shown maybe to have a little higher tolerance to risk, sometimes can look at short-term outcomes rather than long-term outcomes. And just something I was thinking about too is that there's research that shows that your brain is still developing into your 20s, but we decide that 18 is kind of the age where we say, okay, you can make any decision you want to make at this point on your 18th birthday. So it's just kind of interesting that that's kind of become the age where we say that you're completely responsible for your decisions, but it's, you're still having a lot of neurodevelopment into your 20s. So in thinking about this idea of adolescents consenting, what if you have a minor that's refusing a potentially life-prolonging treatment? This kind of ties into, I think, what we talked about earlier, pediatric euthanasia, and that particular instance of that pediatric patient in Belgium who requested to have euthanasia in 2016. So if they're refusing a certain treatment, if they're refusing life-saving measures, you have to think about, are they currently in a state where they have the cognitive capacity to do that? Do they have capacity? Do they understand the risk and benefits? Are they able to really balance the different outcomes of the decision they're making and think about what are the consequences of what they're doing? Is this decision that they're making consistent with what they've done in the past? Is this consistent with their beliefs? Is it consistent with their prior decisions? Why are they making this decision? Do they really understand the efficacy of the certain treatment that we're doing? And then, do you force treatment on a minor? The particular book I was reading that was talking about this section was, do you forcibly intubate a 17-year-old who may be an emancipated minor or may have been given autonomy over their decisions if they're refusing it, but if you don't intubate them, they're going to die. So that's a very complicated ethical situation, and it's one that I think can come up easily. Speaking of emancipated minor, there are certain legal terms that deal with consent of minors. There's certain situations in where minors are given legally the ability to make decisions for themselves. So you first have the emancipated minor. This is a minor who's living on their own. Okay, they're supporting themselves. It could be a minor that's married, one who's in the military, one who's pregnant, or one that's just declared emancipated by a court. There's certain situations, certain circumstances that I think we've kind of already touched on where adolescents or minors may have consent and autonomy over their bodies, and that's things regarding maybe sexually transmitted infections, birth control, situations like that. And also mental health services as well. And then there's this legal, I guess, catch-all term that maybe where you don't fall under those particular circumstances where the court may say you're a mature minor and can make decisions for yourself. And that, from what I could tell, kind of encompasses situations that may not fall under emancipated minor or where a minor has a specialized consent status. So this is a quote by Dr. Lantos, who is in Children's Mercy Bioethics Center in the Department of Pediatrics at University of Missouri, Kansas. And he said, our primary commitment is to do what is best for the child. This fundamental commitment differentiates pediatrics from internal medicine, in which the primary ethical principle is the autonomy of the patient. We are obligated to do what is best in our patient's interests. And I think, kind of translating that, what he was saying there is maybe beneficence has a little bit higher precedence in pediatrics than autonomy. And an example of that would be where if you truly believe that the decision that the caregiver or parent's making for the child is wrong and it's going to hurt the child, then maybe that concept of beneficence overrides autonomy, and that's where you contact CPS and things like that. So this concept of autonomy, from what I read in adult medicine, when dealing with competent adults, is kind of the end of the line, overarching concept in modern medical ethics. But maybe in pediatrics, we give a little bit more importance to beneficence. So we have arrived at my last section here. This is where I kind of talk about some areas maybe where you can go and look at some more information. Maybe you've got some things that you're thinking about now and you want to learn a little bit more about it. So where can I find some resources for ethical considerations? So the AAP has their own committee on bioethics, and they have, it's on the website, it's very nice, it's organized pretty well. You can see different policy statements from the committee on some important topics. And you can just see here, this is just some of the ones that I pulled off the website, and it's some things that we've talked about as well. So guidance on foregoing life-sustaining medical treatment. Down at the bottom, you can see informed consent in decision-making in pediatric practice. So you can go and look and see what the section of bioethics and the AAP has said about these various topics. Then you can decide if you 100% agree with it or maybe you don't. The AAP also has a very nice case-based curriculum for residents. It's got 20 different modules, and it's good for students, it's good for faculty, it's good for everybody, really. And you can just read through the cases. You can read through the different modules. They're about anywhere from 5 to 8 pages. They're really easy to read. It gives you a nice case at the beginning and then talks about some of the different ethical issues that surround that particular case. You can just kind of comb through it, and if you find a topic that you find interesting, you can read through it. And this whole curriculum is available through the AAP's website. I don't even think you have to be on like the LSU server or anything. You can just search it at home and find it and download. And you can download the entire PDF that has every case in it. So I used that as well when I was getting ready for this talk, and it's really easy to read and very, very nice. Pediatrics and Peds in Review also has different articles that deal with ethical topics. Earlier in the why section of the talk, I kind of showed an opinion piece where various people contributed to the concept or the discussion of medical ethics in regards to pediatric euthanasia. So Peds in Review and Pediatrics are also good sources of discussion of ethical topics. The American Medical Society has their Code of Medical Ethics, which was revised and republished in 2017. So it's been around for over 150 years, so you can look at that as well. There's different journals that deal with bioethics. This is a picture of one of the covers of the American Journal of Bioethics. And then our library's website has a section under the ebooks about ethics. So you can go and pull up a full digital copies of various books and comb through them and find different ethical topics that you want to read about as well. And that's just kind of a screenshot of some of the different books they have available as an ebook. So you can, all of these pretty much you can find from your computer and read about all these different ethical topics. So that's pretty much the end. My goal today was, when I started researching it, when I started reading it, I was kind of overwhelmed by all the different topics, and so I wanted to break it down into 5 different questions, and hopefully if you can provide kind of a 1 or 2 sentence answer to these questions, you can hopefully accomplish what I wanted to do. So why are medical ethics important? There's a lot of different ethical concepts, ethical dilemmas that come up on the local office-based situations and also ones that have global ramifications. We kind of went through, when did medical ethics develop? Okay, yeah, there's Aristotle and then virtue ethics. That was kind of replaced by these Enlightenment ideas, and then we have the concepts that we're dealing with today is medicine as a profession and the physician is being fiduciary to the patient. What are the major concepts? This is kind of your board review stuff. Beneficence, non-maleficence, autonomy, informed consent, and then specifically how it relates to pediatrics. The big issue of autonomy, you got this interesting relationship between the parent, the physician, and the patient, and how that all works together to make the decisions for the patients. And then where can I go and find more information? So start on Google, start on the library's website, and you can find a lot of good resources and opinions that can kind of help you make decisions and frame your ethical decision making for some of these complicated issues. So here are my references, and then I want to thank y'all for coming, and if y'all have any questions or any topics that you want to talk about, certainly welcome.
That was a great job, Randal, and you clearly achieved your goal. I think you covered many of the key issues that we face every day, made it very clear that these are concepts that you need to
be aware of and practice every day when you see patients and work with their parents. And so I think we should have clearly whet everybody's appetite for more. So let's open this for any questions or comments. Okay, quiet group. So if you were able to attend our bioethics conference this past Saturday, some of the same things that Randal discussed came up related to the genetic advertising to consumers and products available to consumers, as well as even the things that we do for newborn screening and other things. Did that come up as an issue as you were looking at the genetic screening and how we should approach parents?
Well, I think that I didn't see anything specifically related to newborn screening. I think that what is important to keep in mind when you deal with things like that is there anything that can be done to help the patient, help the child in these particular diseases that you're testing for? So a lot of those metabolic issues, that is something that we can do something about. And then while the child is certainly not able to consent to that information or obtaining that information, if it's something that can lead to a better outcome for the child through intervention during their pediatric time, I think that it's important to keep in mind that that concept of beneficence maybe overrides the fact that the child can't give consent at this particular time to that testing. Now, if they had, if you had a family that didn't want the metabolic screen, they declined it, I think that is a little trickier ethical issue. If maybe you don't find something that the child could die from if you don't do the metabolic screening, and if the parent refuses that, I think that's becomes a more complicated medical issue, ethical issue. I don't know the answer to that.
In the state of Louisiana, in the by statute, parents do have an option to opt out. We just kind of assume that everybody's opting in, but there are some states where you actually have to sign an agreement to do that. I've only had one parent, really two families in all the years that I've practiced who did not want newborn screening. And basically, I had them sign. I try to these are disorders that there is intervention for that what makes newborn screening so vital is because we can't make a difference with mortality of children. It will have to be some
Junie?
Randal, did you come across anything about the ethics of both at-home genetic screening tests, the 23andMe ancestry?
No, I didn't. I know that's really kind of taken off here in the last year or two, and I guess there's nothing stopping somebody from doing that test in their child and sending it in. Since that kind of is in the private sector outside of the physician's office, I think that becomes pretty tricky, and it doesn't mean that we shouldn't have an opinion or an ethical responsibility to comment on that, but it does make it a lot more complicated. That it's something that the physician. I mean, it's not something you come to the doctor's office and get it. It's not a test you get at the doctor's office necessarily. It's just by mail, and so kind of falling outside of our purview. I still think that's important to have an opinion on. Yes, sir.
Yeah, but those don't go down to the medical resolution level that we need in genetic testing, so they're not going to identify anything other than paternity questions or background of my family questions. Yeah. And that happens. Those aren't trivial at times, but it's not medical grade genetics.
Not yet. I think it could.
There will be. That's right.
There are some tests that that's what they claim. But you're going to be at risk for this level. More likely we're at risk for
all those things. They're headed that direction.
Yeah.
Yeah, a lot of them are really at this point saying you have a potential risk for heart disease or Alzheimer's or something like that. And but one of the things that the genetic counselor who spoke Saturday said that if you're going to do testing to look at your disease risk or to identify an underlying disorder in your family, that you should make sure you have health insurance before you do that test, so that that test will diagnose you after you're already insured, just in case things change, as they might in the future in terms of pre-existing conditions. So that's an important concept. So yes.
Did you come across anything where the pediatric patient and parents disagree about treatment modalities or the goal of therapy and health benefits?
I didn't come across anything specifically related to that. I think that does kind of tie into this concept of the minor's consent, specifically with like adolescents, and like kind of what we talked about. If you have an adolescent who's refusing, some kind of life-saving treatment, there's those particular special legal circumstances with the emancipated minor, the mature minor, that situation can kind of fall under, and also looking at why the child or the adolescent is making that decision. Is it consistent with what you know about their beliefs and their goals? All those things I think are important to keep in mind whenever you approach that kind of situation.
And I think also, because there are situations where we really hear as people when you've got a 15 or 16-year-old and they really grasp that.
Yeah.
But they're, a parent has a hard time letting go of a child. And then there can be some major conflict.
Yeah, I took care of a 16-year-old who had failed 2 bone marrow transplants, and she basically said, I don't want a 3rd transplant. And her parents said, no, you have to have a transplant. And the physician's evaluation, psychiatry evaluate whether she was competent to make that decision and understood the ramifications of it. And the ultimate decision was in favor of the child. I think 2 important things. One is you definitely don't want cases like that to end up in the court or the court of public opinion. Those should be handled in a physician-family relationship that is very attuned to communication in the family, because that's how it's been done for years and years, generations, and that's the best way. That's the best outcomes are that way. When it ends up in court, it often turns out disastrous for everybody involved. And the second thing is, this particular case that I was involved in, the child, the teenager understood the ramifications of her decision. She asked the right questions and elicited from her physicians that, yes, the likelihood of success on a failed transplant at that time was less than 2%. And she says, for a 2% chance, I'm not willing to go through all the things I've been through already twice. And so those things change, and you really have to have the best available information on risk, benefit, likelihood to weigh into those equations.
And then one thing, and that kind of reminds me of one comment I did want to make was, in regards to refusing or life-saving treatment or withdrawing care, that there is a very important distinction between that and the concept of pediatric euthanasia, where you're withdrawing care or not doing something versus the active element in pediatric euthanasia, where you're actively causing someone to die. So while they seem like they may overlap some, there's a real important distinction there, and I think that distinction is really important to keep in mind as we, I think, in the future are going to have to approach this pediatric euthanasia, and I think that is something that will come up in our careers.
Yeah, I think that's a really good point. And the other thing that Randal raised that I think was really important is the different role that people who take care of children have than people who take care of adults. Because you are not only taking care of that child, but you become that child's advocate. And so if a parent is making the wrong decision about that child, you need to make the decision about when to step in, how to step in, the degree of potential damage that might occur to that child based on the parent's decision, so that you could then take over the decisions for that family. And that may mean counseling, it may be interaction with a third party, it may be ethics committee, and it could be the courts. And frequently, we're always going to the court when we think a child may be abused or mistreated. That's a very important part of anybody who takes care of children, to recognize when that's going on and take over what needs to happen for that child. So I think that was a really important component of this discussion, and a good reminder of what we need to do as physicians in those settings. Questions? Okay, Randall, great job.
Thank you.